Hi, everyone. My name is Anne-Marie Hayes, and I'm a research associate for the Joplin Campus of KCU. Today, I'll be introducing our speaker, student Dr. Keanna Theobalt. She's going to be talking to us today about her cadaveric study, as she's an anatomy fellow here at KCU. So to begin, to introduce our speaker, student Dr. Keanna Theobalt is an anatomy fellow down at the Joplin Campus. She is from Southern California, but completed undergrad at Southeast Missouri State University in Cape Girardeau, Missouri. She was a collegiate track and field athlete, which has been her main inspiration in focusing her research on the muscles of the leg. Keanna is an aspiring sports medicine physician where she hopes to integrate her passion for athletics with her interest in science and medicine. So with that, the floor is yours, student Dr. Theobalt.
Awesome, thank you. Okay, I'm gonna go ahead and get started. So as Anne-Marie said, I am Keanna. I'm a fellow down in Joplin, and I had the privilege of exploring the soleus this past year for my fellowship project, and I was trying to look at the varying patterns and characteristics of the soleus muscle. So usually everyone starts by asking me, how did I decide to research or perform research on the soleus? And like she said, I was a collegiate athlete, so I'm very interested in muscles and bones, especially of the legs because I ran track. Well, actually I pole vaulted, so I guess I did field. But anyways, I'm an aspiring sports medicine physician, so these things are very intriguing to me. Something very important in sports medicine is injuries and making sure that we diagnose and treat and find the proper prognostic protocols for those individuals. So I knew that going into my literature review, these are things that I was very interested in. So when determining what research to do, especially when starting from the ground, which is what we do as fellows, you got to do a ton of literature review. You got to see what's out there already and what needs to be done to fill those gaps. So that's the mindset that I was going into. So looking at the literature, first of all, what does the literature say about soleus injuries? Well, they say that knowledge of connective tissue distribution is crucial for interpreting MRIs. Evaluation of structural diversity and its relationship to strains needs to be evaluated. The soleus is very complex. So to determine prognosis of those lesions within the soleus, we must consider anatomy and its functional roles. We have to consider the distribution of connective tissue, aponeuroses, to determine a reproducible prognostic pattern, and the specific subtypes of the soleus muscles must be considered to classify specific injuries. I was very determined to see, okay, so what exactly do they say about muscle injuries in general? So the literature says that there's no agreement on classification systems for muscle injuries because it does not include the type of tissue involvement. So muscle fibers, tendons, aponeuroses, and the limitation of these muscle injury classification systems is that they fail to include the complexity and variability of specific muscles, and they would be more clinically relevant if they reflected the anatomical and functional role of specific muscles instead of just saying in general, here's a muscle classification system for injuries. So with all of that being said, I decided to do my research on the connective tissue distribution within the soleus. So let's start with the introduction because the soleus, like I said, is very complex. The soleus is part of the calf muscle complex, the triceps surae. It's located in the posterior superficial compartment of the lower leg. It's deep to the gastroc. So if we're looking at this picture, we see the gastrocs have been cut, and underneath that we see the soleus. It's composed of type 1 fibers, which are known as slow twitch fibers. And we typically think of a muscle to have a rapid contraction for strong, quick movements, but the slow twitch fibers of the soleus allow it to maintain contraction for a long duration of time, giving it the ability to perform many different functions, and those include to control our posture, support the body, center of mass during walking and running, plantar flexion, to maintain posture, especially on two feet, It serves as a venous pump for the legs because we need to, as that blood makes its way back up to the heart, we gotta reciprocate that force of gravity, and it serves as a power generator for the muscles around it. The soleus has the largest PCSA, which is the physiological cross-sectional area among the human skeletal muscles in the lower leg. Because it is composed of many short muscle fibers, literature says that the muscle fibers range from 3 to 4 centimeters, and that's pretty tiny. So to accommodate all of those muscle fibers, we need a structural skeleton composed of non-contractile tissue for the fibers to hold on to. And this is where we get this unique, complex architecture of connective tissue within the soleus, which I'll be talking about from here on out. So let's go ahead and go through the connective tissue because it's kind of intense and I want to make sure you guys are following me. So let's start with the Achilles tendon. The Achilles tendon is going to be distal. So this is the superior and this is the inferior view. The gastroc is going to be laying on top of the soleus, and those tendons are going to fuse distally and create this Achilles tendon. And then we have the posterior aponeuroses, which is shown in this green bracket, and that's going to cover most of the posterior surface. So that posterior aponeurosis, remember that because it's going to actually create an invagination. You can kind of see that here. It looks like a little bend or like it had been folded in half. Well, that's actually penetrating to the anterior surface right here, giving off this central tendon. And that's going to be our green arrow here. If you look at this picture right here, all of the muscle fibers have been removed, and we can see that the posterior aponeurosis, so imagine the soleus laying flat, like on its back, and that posterior aponeurosis gives off this invagination to become that central tendon. And then we have our origin tendons, the anterior surface as well, and that's going to be where our soleus connects to our bones. And we have a medial and lateral origin tendon. We can also see that in this picture here. However, I think it's a little bit of a misrepresentation because the origin tendons don't actually go all the way down. And we can see in this picture that the origin tendons actually span a greater amount of that muscle belly than this picture shows, but it's a good representation without any of the muscle fibers there. So those origin tendons are also going to give off an invagination that penetrate internally into the muscle, and that's going to create our intramuscular tendons, which we can see in this cross section. So we can see our origin tendons still in these brackets, and I apologize, it's a little bit thin, but I think you can still see it. So this is our medial origin tendon, and I like this cut because you can still kind of see the anterior surface. So here's our origin tendon, and it gives off that intramuscular tendon. It's just a continuation where more muscle fibers are attached. Same thing on the lateral side. We have our origin tendon, and then that's going to penetrate the muscle to give off an intramuscular tendon as well. And here's some arrows so you could follow that a little bit better. Okay, so how exactly did we follow these tendons through the muscles? Well, first we used 40 muscles from 20 formalin-involved cadavers, 10 males and 10 females. I thank KCU's Gift Body program for providing the donors, and I thank those individuals and their families for their generosity and support of medical education. We dissected and removed from the posterior approach. So here you can see the cadaver is actually prone. And this is going to be the posterior leg. We reflected the gastroc, and here's the exposure of the soleus muscle. We removed both muscles from each leg and took pictures anterior and posterior surface. And before we took any measurements, we used a 3D scanner to create images for noting variation within a single individual. So soleus muscles displaying any unique characteristics were subsequently reconstructed in 3 dimensions using a 3D scanner for better presentation and visualization of that variation. So here we see a typical symmetrical morphology that's currently described in literature. We see bipennate fibers. on both sides, and some variations are included here before we reconstructed them in 3 dimensions. We have hypopennate, so no pennation on that anterior surface. However, the left leg did have some fibers exposed on the anterior surface. Same with this. And in these pictures, if it has a string, that means it was on the left side, left leg. Here we see that bipennate fibers with no central tendon, and the opposing leg has full connective tissue coverage on the anterior side. And here we see unipennate and bipennate. So here's some examples of the 3D images that we created. You can scan that with your phone and see a 3D image of a varying morphology if you want to. I'll give you like a couple seconds to scan it with your phone if you just are curious on what exactly I mean by that. Okay. And so for our measurements, we cut the muscle in cross-section at 3 locations, proximal, middle, and distal, relative to the size of its muscle belly, which is measured here in the anterior position. And we were curious to follow the internal tendinous structures throughout the course of the muscle through those cross-sections. And all measurements were taken on Image J software. So we measured on the anterior surface both the central tendon, which is this measurement in A, shown green, and the muscle belly in pink. And then we use that to cut it in 3 equal sections, proximal, middle, and distal. This picture is showing us that we followed that internal structures within the muscle. So we can see our origin tendon here, and then that continues as an intramuscular aponeuroses. We see our central tendon, and on the medial side, the same thing. We see our origin tendon here, continuing internally to form that intramuscular aponeuroses. And then we noted any changes in that orientation. So we also noted, did the central tendon span the entire muscle, since it was described to be an invagination of the posterior aponeuroses, meaning it should have came directly off that posterior aponeuroses and spanned the entire length of that muscle. Did we have any extra invagination? So this over here is actually showing us an additional invagination of the posterior aponeuroses. And things like, did the aponeuroses on each side connect? Here, sometimes they actually fuse together to separate the muscle into anterior and posterior compartments, which we'll see a little bit later. So I decided that I was going to combine my results and discussion for better flow, because it's kind of a lot to keep track of. So after I present a couple of things, I'll add a discussion point. And I also want to mention that we're still in the process of doing statistical analysis on our data. So here I present to you more descriptive analysis of the data. So first, our anterior morphology. We classified 5 different types of soleus muscles. We have our typical anterior bipennate portion, which is going to be that bipennation on the anterior surface. That could also be laterally deviated. So we see our pennation, it's not symmetrical, it's more on the lateral side, and then it can be medially deviated, which is shown in this muscle. We can have no fibers on the anterior portion, and that is shown by this muscle here, and then it can be unipennate, so we only have one side of muscle fibers on that anterior portion. So most of our samples were actually anterior bipennate and midline, which is shown by gray here and green. And then, although we did have some representation of the other morphologies. Looking at varying morphology within an individual, 55% actually had the same soleus on each leg. So whether that was the anterior bipennate morphology or any of the other ones, they were same on both left and right side. However, 45% actually had varying morphology on each leg. So one maybe was anterior bipennate and the other one was unipennate, shown in this picture, which is actually surprising for me. I wasn't expecting to see that much variability within a single individual. So a discussion point for the anterior morphology. The bipennate structure is believed to have a role in ankle plantar flexion because it attaches to that central tendon, and that central tendon connects distally to make the Achilles tendon. It is also a main contributor to the venous pump, where blood is pushed back up to the heart. So our question was, is this morphology adaptable for people that maybe shake their legs, which I do, which is why I noted this. And I usually only shake one leg. So, you know, people, I don't know if it's due to anxiety or something, they shake their leg and their legs don't necessarily get tired, but it is that rapid continuous motion for long durations, which is what the Soleus is known to do. Persistent toe walking, so in people maybe with ADHD or autism actually walk on their toes more often than others, so this can actually contribute to that differing morphology. A shorter person needing maybe to reach higher things up high, going on their toes more often. These are things that we don't necessarily come to our attention very often, but noting that what the muscle does in ankle plantar flexion kind of sparks our interest on these different adaptable characteristics. So the variations can also be due to leg dependent activities. So maybe sports that are leg dependent. So maybe you kick, or in my case, pole vaulting, I jump off of one leg. So that could be contributing to that ankle plantar flexion. And driving, we didn't know, this is not something that we think of all the time, but we all drive with our right leg, right? And we are continually plantar flexing that foot. And so maybe that can be contributing to why our leg is, or our muscle has a different morphology than the opposite side. Looking at the central tendon, we wanted to know, is the central tendon seen on the anterior surface like we see in this picture? 30% yes. 30 muscles yes, 10 of them no. And of those 10, is it because the central tendon and the origin tendon were combined? So if I'm using this picture as a reference, so here's our origin tendon. That means the origin tendon would come all the way across, cover these fibers, and actually attach to the central tendon. So there would be only muscle fibers on one side. And 7 of them no, and 3 of them yes. If you actually scan one of those QR codes, this was one of the 3D images that I was trying to show on that. Another one was, did the CT or the central tendon span the entire thickness of the muscle? Remember I said that the central tendon is an invagination of the posterior aponeuroses. And literature is describing the soleus to have 2 compartments, a lateral and a medial compartment. And that is made through this central tendon. So actually 19, yes, it did span the entire thickness, but 18 is no. So that's pretty high in my opinion. That's almost half. And 3 actually didn't have a central tendon. And I want to make note that 3 of those muscles that I showed for the anterior morphology were actually hypopennate, which is the same 3 that did not have that central tendon. And then, was our central tendon actually present in all aspects or in all locations of our cuts? So proximal, middle, and distal. And by the distal region, we actually had 95% of our muscles showing that central tendon. And that's important because actually during injury classification, which is on the come up right now, it's not solidified, but they're only cutting the muscle into a middle. So we have one cut straight through the middle, and then everything above is known as the proximal region, and everything below is the distal. And so, first of all, the central tendon is recommended to be used as the deciding factor on muscular dominance. So this And my question is, can this be the case if the central tendon does not span the entire thickness of the muscle? And furthermore, should the muscle be considered to have more than just those two compartments? So like we will see in a couple more slides, our intramuscular aponeuroses actually may connect internally to actually separate the muscle into anterior and posterior compartments. So that creates an additional compartment that the soleus was not known or considered to have. Strains of the central tendon are commonly associated with spontaneous rupture of the Achilles tendon. So the insertion of the central tendon and the possible variation of where that inserts in the anatomical arrangement may play an important role in that spontaneous tear, which I thought was very interesting. And then return to playtime is actually longer, well, said to be longer in the central tendon or with central tendon involvement. And that's because the central tendon acts as an origin and insertion point for multiple muscular compartments. So if any movement is affecting that rehabilitation and recovery of that tendon, it's going to be affected, right? Because although it is stabilization, it can also be pulled on the opposite side. So we got to keep that in mind. So for intramuscular aponeuroses, that's where origin tendons internally penetrate the muscle and act as a origin or insertion point for muscle fibers. So we're looking at in the proximal region, did the intramuscular aponeurosis meet to split that muscle into an anterior posterior compartment? 25 muscles, yes. 15, no. And distally, did the intramuscular aponeurosis, were they present? So in 24, a little over half, they both were still present. And 7 actually weren't there anymore. 6 for medial and 2 for lateral. This was an interesting point because we were seeing if the muscles actually had a dominant connective tissue, did that stay present throughout the course of the muscle? Because as we get distally, we know that the muscle fibers actually decrease and it becomes very thin. So did we actually need those aponeuroses still? That's what we were trying to figure out. So looking at our medial intramuscular tendon, or we classified it as our IMOT, our average width was actually the highest in the middle portion, which is what we were expecting. In literature, it says that since the bulk of the fibers or the soleus muscle is the thickest in the middle, we expect that that width is going to cover more of those fibers. But we can see that as we make the course through the muscle, it kind of small, big, and then small on both sides. And then looking at the lateral intramuscular tendon, we see a little bit of a different course than the medial intramuscular tendon. So the average width on the right leg was way higher in the proximal region than in the other two regions. Although the middle region for the left leg was higher, we still see kind of a decrease in that width of the lateral intramuscular tendon. And that's, I think, going to play an important role when I come to describe what is believed to be the specific functional role of each side of the muscle. So just keep that in mind. I know it's kind of a lot to keep in mind, but it starts to make sense, I promise. Okay, so our origin tendon versus that intramuscular tendon, we actually found a statistically significant inverse relationship between the origin tendon and the intramuscular tendon in each location. So distal, or proximal, middle, and distal. We found that as the origin tendon increases, the intramuscular tendon will decrease and vice versa, which is also representative of the previous slide where we looked at the average length of those tendons. However, in the medial side, we did not find statistically significant relationship except for the proximal region, but barely. So this also reflects that average length, though it varies. Remember, it went from low to high, back to low. And also, this also promotes the point that maybe the lateral side is more general. It has a typical characteristic in orientation compared to the medial side, and maybe the medial side is actually more adaptable, and it changes depending on what the person may be using that leg for. So a point of discussion, the lateral soleus is known to be the part of the soleus that performs the ankle plantar flexion with an average fiber bundle length greater than the medial side. So considering sports that have a lot of jumping and propulsion, so plantar flexing will be laterally muscular dominant. That's just a concept, not for sure. Does this mean that the intramuscular tendon on that lateral side is longer or shorter to maximize the ability to support the dominant musculature? That's what we're thinking right now. Compared to the medial side, this medial portion is known to be the stabilizer with a shorter average fiber bundle length. So sports that require stabilization, like stability of stance, so in tennis or a goalie in soccer, the D-line, O-line in football, may be medially muscular dominant. And does that mean that the IMOT is longer or shorter to maximize that ability to support the dominant musculature? So how I try to explain this is, do greater angles of pennation correspond to a longer or shorter tendon? Because if we think about greater angles corresponding to the contractile ability, it's probably greater with greater angles because we need to close that gap, right? The tension or force created during that contraction needs a sturdy base to hold on to. Those muscle fibers need somewhere to hold on to. So if we think of a rod, a short, broad rod is harder to break and therefore perceived as sturdier compared to a long rod that has the ability to cover more surface area and have more fibers attached to it. But as it gets pulled on, it may be flimsier and easily broken due to longer leverage and flexibility. So that's just a point to keep in mind when we're trying to make that relationship, which is what we're trying to do. So with all that being said, the soleus is not anatomically homogeneous or homogeneous. Current literature describes the soleus as a muscle with multiple tendinous structures, but fails to classify those structures to represent different morphologies that we just saw within the soleus. And identifying those patterns on all portions, so anterior, posterior, and internal surfaces of the soleus, will be a useful tool in recognizing injuries in those locations. And since injuries occur at that myotendinous junction, so where those fibers connect to those tendons within the muscle, is actually the weakest part of the muscle, and it's important to recognize those dominant patterns and the relationship to those fiber attachments. Some limitations on our study is our data was based on elderly cadaveric specimens, which may have changes in architecture due to aging, and this can misrepresent the data in young, healthy, active adults. Structure may be different in size due to the embalming process of the cadavers. Our sample size is a little low, and knowledge of demographics such as what they did, what sports were they involved in, different medical history, may be something that we could have found a correlation, but because we don't know those, we can't make those assumptions. And I just want to acknowledge my research team, my companion fellows, our anatomy department, the committee, my brother for helping me create those 3D images, and all of you showing interest in my research and giving me a reason to show off all my work. So thank you guys.
Awesome. Thank you so much, student Dr. Theobalt. Great presentation. Oh, sorry. Great work, great job. Everything was super clear and you were very articulate. So wonderful presentation. If anyone has any questions, feel free to either raise your hand in Zoom, or if you can't talk, type them in the chat and I'll read them out loud so that they're in the recording later. So yeah, any comments, questions?
Keanna, can I ask you?
Yes, sorry, I cannot see anyone, but yes, I can hear you.
Thank you for presentation. And again, my question is the same. Remember, we have gastrocnemius
Yeah.
and Soleus. What
Uh-huh.
Soleus can do and gastrocnemius cannot do.
Yeah. Okay, so I did look this up because I was like, you know what? I need to know this. Is it plantar flexion during a bent knee? So
Yeah.
if the person's squatting and they can't go on their toes.
This is how practically we distinguish between these two muscles in the patients.
Okay. Yeah, so
you.
Dr. Mehrhoff actually asked me this during the symposium, how if a patient is presenting to me with a calf injury, how I would distinguish that from a gastrocnemius versus a soleus muscle injury. And although the gastroc and soleus both play a role in plantar flexion, the soleus plays a role in plantar flexion when the knee is bent. So we would ask the patient to squat down and then go on their toes. And if they could not, then we would be isolating the soleus injury.
Okay, thank you. And you mentioned about unipennate and bipennate. On both sides, anterior and posterior, you see similar or?
No, just on the anterior side. So we would just see, so everything in front of, there's two aponeuroses, the anterior and posterior, and anything above or in front of that anterior aponeurosis would be the bipennate versus unipennate morphology. So within the muscle, there's a bunch of different angles of pennation, but specifically on the anterior surface, since it's known to do a very specific job, that's what they're classifying.
So posterior all were unipennate.
Well, I wouldn't say all of them are unipennate, but depending on the specific side, because they're just talking about that one fiber bundle, it would be unipennate. Yeah. That makes sense.
Okay, thank you.
Any other questions, comments? Looks like you have a question in the chat. It says, do you think tendon patterns have any effect on the flexibility of the soleus and the ankle joint?
Yes, I do. I think that because of the different and the numerous amounts of patterns of those tendons, I think it gives the soleus an advantage of working in a lot of different ways. So it's very, it can compensate for different movements of the ankle. And I don't know if it's like general structure would have any relationship to that, but I definitely think it gives the soleus an advantage for ankle joint stiffness versus flexibility for sure.
Any other questions, comments? Well, if not, thank you so much again, student Dr. Theobalt. Great presentation. Thank you so much for speaking in the journal club.
Thank you guys.